Okay, everyone, thank you for your patience as we get settled here and ready to go. My name is Nick Reed. I'm an associate professor in the Department of Occupational Science and Occupational Therapy at the University of Toronto in Canada. I'm also a very proud member of the IBIA and one of the leads on our Concussion mTBI special interest group. And we're just thrilled to have you with us today to learn from an amazing researcher, clinician, and colleague, Dr. Noah Silverberg. You're in for a real treat. Just a few words of thanks before we get started because we tend to run out of time for these. Thank you to our speaker today, Dr. Silverberg, for sharing his great work with us. Again, you're in for a real treat, so thanks for joining us, and thanks to Noah for doing this. Thank you to everyone at IBIA, Jennifer in particular, for making sure that this can all happen and keeping us all organized. And I think very importantly, thank you to all of you for carving out time. We know how busy life is, how busy your days are, and we hope you find this session interesting and very useful in your professional and perhaps personal worlds. So thank you all. What I'll do now is I will introduce our speaker today, Dr. Noah Silverberg. And just before I do that, letting folks know that we will save questions for the end of today's webinar. We'll have a good amount of time for some questions and discussion. The way we'll do that today is via the chat function on our Zoom room here today. So if you do have questions, feel free to put those into the chat, and you can even put them in throughout the presentation, but I will be reading them out to our speaker today at the end. But if it's top of mind and fresh, please put it in the chat and I'll make sure I get to that towards the end of the presentation. Okay, without further ado, I will now introduce our speaker for today. Dr. Noah Silverberg is an associate professor in the Department of Psychology at the University of British Columbia in Vancouver, Canada, and a principal investigator in the Rehabilitation Research Program of the Vancouver Coastal Health Research Institute's Center for Aging SMART. Dr. Silverberg is also a board-certified neuropsychologist. He worked as a clinician in concussion and brain injury rehabilitation for 13 years before transitioning to the University of British Columbia in 2020. His research program has focused on psychological contributions to concussion recovery and evaluating non-pharmacological therapies for this condition. He is an associate editor for the Journal of Neurotrauma. Dr. Silverberg has served in leadership roles with the Canadian Concussion Network, Brain Injury Canada, the American Congress of Rehabilitation Medicine's Task Force on Mild TBI, and on initiatives led by the National Academies and National Institutes of Health. He has authored and contributed to local and international clinical practice guidelines. And above all those things, I know Noah as a very thoughtful, caring, and supportive colleague who's always open to progressing this field in incredible ways. We're going to hear all about his great work today, in particular around fear avoidance and persisting symptoms after concussion. We're so grateful for the work that you do, Dr. Silverberg. Thank you for being with us today, and I will pass the mic over to you.
Great. Thank you so much for the invitation to be here and for that warm introduction, Nick. Always appreciated. So I'm joining you today from Vancouver, British Columbia, Canada, which is situated on the traditional unceded territory of the Musqueam, Squamish, and Tsleil-Waututh Indigenous peoples. I've had research funding for some of the work that I'm going to be sharing with you today, primarily from CHR, the Canadian Institutes of Health Research, and some others that are less relevant for today's presentation. I think Nick actually mentioned these other roles and various unpaid work in his introduction. So I think we can move into it. So just position the work I'm going to be talking about today in my research program more broadly, which is that, we've known for at least a century probably that psychological factors are important for shaping recovery from concussion. But this, for many years, has been kind of a black box, and I think only more recently we're getting some clarity on which psychological factors specifically are important and how they operate to influence recovery, and we need that level of specificity if we're going to be able to design effective psychological intervention. So that's been the primary motivation. So I'm going to be talking to you today about one kind of psychological risk factor, if you will, in particular, which is fear avoidance behavior. I'll start with just a general introduction to how fear avoidance works, and how it may contribute to symptom chronicity in various health conditions, including concussion. The second learning objective is to really more dive into the empirical literature and kind of summarize what we know about fear avoidance after concussion in particular. And then lastly, we'll talk about some treatment approaches. You know, if you agree that fear avoidance is a problem, you'll probably want to understand what can be done about it. So first, some general background. So I think the first thing I want to make clear is that the fear avoidance response is a normal and adaptive, evolutionarily helpful response. And I'll just walk you through an example where the situation is a dog lunges towards a person. And I'm going to ask you to imagine that this is kind of an ambiguously dangerous situation. The dog could be playing or, warning, and not necessarily lunging to bite, but it's unclear. In any case, the person is startled, they experience fear, they have that kind of fight or flight reaction in their body. They move away from the dog. They may interpret this situation as a possible but not a definite threat, and might be willing to kind of carefully approach the situation again to learn more about it. So there's still some element of fear learning here, but it's not exaggerated or out of proportion. It's also possible that the person in this situation could have interpreted that lunge from the dog as kind of a close call, something more threatening, and they might be in this kind of anxious and vigilant and avoidant state, which is called different things in different kind of translational theoretical models, like the pre-encounter phase or the potential threat phase. And after some time passes, they may reflect on what they experienced and realize that, maybe the dog was just defending itself. They might eventually feel comfortable kind of approaching dogs, or just accidentally encounter dogs in ways that are not threatening, and be able to move back to this kind of approach with caution. Way to go about things, and essentially just get on with their lives. So this is kind of fear avoidance as it works normally, and its neurobiology is well established. I won't go over this in detail, but just to mention briefly that we have these overlapping and complementary brain circuits for these two processes. The first being the learning of fears, so forming associations of stimuli that might be threatening. And you can see that the hippocampus and amygdala are core players in that circuit. And then there's the emotional regulation circuit, which sort of kicks into gear whenever we encounter stimuli, including avoided stimuli, because completely avoiding them is impossible. Inevitably, they'll encounter them to some degree. And that sensory information will be tagged as salient by your amygdala, also incorporating interoceptive signals from the insula, which are fed to the amygdala, and then forward to the prefrontal cortex to help kind of evaluate the threat and mobilize a response if that's necessary. But there are also reciprocal connections where prefrontal cortex inhibits the emotional reaction by like dampening down activity in the amygdala, and allowing for that kind of approach of stimuli or situations that have uncertain threat, what we might call cautious exploration. So that's when things go well. Things could play out differently. So the same person who had a dog lunge toward them may play back what happened in their mind in kind of an excessively negative way. Like they feel certain that the dog was trying to attack them. They might ruminate on how it could have been worse. For example, I could have been mauled or seriously injured, or thoughts like, what if my son was there with me? They might have negative appraisals of their ability to cope, like won't be able to handle myself in that situation. They might develop excessively negative predictions about the future, including the risk of a future dog attack, and they may be kind of stuck in this anxious, vigilant, avoidant state as a result. Now, when you start avoiding, you're going to want to keep avoiding, because avoiding feels good, makes you feel safe. It gets rid of the anxiety. and that's called negative reinforcement. When you keep avoiding, what happens to the fear is that it sticks around or even grows over time because, of course, you never get the opportunity to have positive, non threatening encounters with dogs. And over time, we can see kind of a growing mismatch between um, perception of risk or potential harm and the actual danger. So that's one problem, is this negative reinforcement loop. Another problem is called fear generalization. Again, sticking with the example of dogs, if it's a German Shepherd, say, that lunges towards you, it's common to not only become afraid of German Shepherds, but other kinds of dogs that maybe resemble them, and over time, maybe all kinds of dogs. And we see this play out in other conditions. For example, people with chronic low back pain, it may initially be one particular movement that flares up pain and is frightening. But there may be some generalization over time to other kinds of movements and physical activities that people fear will worsen their problem. It's called kinesiophobia. PTSD is probably the best example of this, where, initially some terrifying thing happens, but over time people develop a very generalized and broad view of the world as an unsafe place. So that's kind of extreme fear generalization. So fear and avoidance behavior happens in lots of different health conditions, including chronic pain after musculoskeletal injury, where it's probably best established, but also conditions like headache, PPPD, chronic fatigue syndrome, certainly anxiety disorders. So we know that avoidance behavior contributes to both symptom chronicity and disability across these conditions. It does that through at least three mechanisms that I'll just walk through now. The first, deconditioning, is probably most well described in musculoskeletal injury kinds of samples, but is probably relevant to any condition where inactivity could cause problems, and symptoms such as fatigue and activity intolerance, basically through disuse. The second is sensitization, this idea that triggers of symptom flare-ups actually they trigger more easily over time. People become more sensitive to triggers. So the thought is, and this has been well described in headaches, for example, bright lights trigger headaches in part because they are persistently avoided. And the opposite is true as well. When we gradually expose people to repetitive light flicker and glare, they're better able to tolerate that. It doesn't trigger a headache as much. The last is somatization. And this is where anxiety, including sympathetic nervous system arousal, causes symptoms like fatigue, headaches, difficulty concentrating, other non-specific symptoms that could be attributed to another problem. And part of anxiety involves being concerned about what's happening in your body. And in that state, you're going to be kind of on the lookout more for bodily sensations that may be of concern. You're going to more likely notice benign sensations, but potentially interpret them as concerning. And you've probably experienced these things to some extent in your own life, especially I think about deconditioning and sensitization in the context of, having a terrible flu and being in bed for a couple days, and you get out of bed and you find the bright lights so bothersome, that sensitization, and that, you get out of breath just going up the stairs. There's a bit of deconditioning there. It only takes a couple of days for that to happen. So there are probably both direct and indirect effects on disability here. The indirect effect is that avoidance behavior over time can um, cause symptoms to persist or even get worse. And of course, when you have worse symptoms, you'll have worse disability. But there's also a direct effect, right? Because when people are avoiding, they're not doing stuff that they need or want to do, which is in part how we define disability. And in fact, there are some patients who avoid so much that they actually have minimal symptoms because they're avoiding anything that might cause symptom flare-ups, but that also means they're not doing much at all. All right, so that's fear avoidance in general. Now I want to see how it looks after concussion. So, as I'm sure you know, in the early days after concussion, symptoms can be provoked or worsened by various kinds of triggers like light, noise, motion, mental, physical exertion. And so people are getting feedback from their body, and also from others like healthcare professionals. And the message there is take it easy, don't do anything to worsen your symptoms. You know, your brain is vulnerable, said explicitly or implied. And so there are good reasons, in other words, in the early days, to do some avoiding. And that's not necessarily a problem. It may, in fact, be adaptive, and it's only when this fear avoidance grows or continues for longer than it needs to that it becomes a problem. And so we have some evidence of this pattern. The data I'm showing you here are from a few hundred adults seen at a concussion clinic in Toronto, the Hull Ellis Concussion Research Clinic. And what this is showing is that patients who never avoided a whole lot are doing well. They have the lowest SCAT symptom scores 8 weeks later. Those who were avoidant early on, but their avoidance decreased, also look pretty good and not much different from the group that never avoided. But those who have more persistently high fear avoidance, and especially those who have increasing fear avoidance over time, they tend to have more post-concussion symptoms at follow-up. Here's a different data from a research group in New Zealand, and here the outcome is return to work rather than symptoms. And what we see here is that people, again, who start out with some fear avoidance, but that fear avoidance decreases over time, they have good work outcomes. So that you can see this size of the blue bar relative to the green bar. Green means not back at work at usual hours, blue is. They're doing very well. And it's the groups that are, again, have persistently high or worsening fear avoidance, the proportionately most of those, or the majority of those people, are off work 6 to 9 months later. Okay, so most of the data I'm going to show you now is for patients who are sort of weeks to months post-injury. So they're in those sort of high or low-high groups I was referring to earlier. They continue to avoid things. This is one of the first studies we did in the area, and we started with a fairly narrow focus, which is triggers of headache, particularly after concussion. So we just asked people what brings on your headache and how much do you avoid those things. And that's the data that you're seeing here, is how much of the time they avoid things. Now, most of these, like bright lights, computer screen, noise, stress, are common to headache disorders more broadly, not just post-traumatic headache. But I'll just point out that mental exertion seems a bit more unique to concussion. We don't see that so much in primary headache disorders. Now, these again are just headache triggers. So if we had asked the question differently about avoidance more general, we would probably see some other things, which from clinical experience include things like avoiding, running into familiar people or busy places like coffee shops and that sort of thing. Here's some more potential evidence, or at least evidence consistent with the idea that these patients are avoiding mental exertion or sustained mental effort. So this is a correlation between two subscales of a cognophobia questionnaire. So the degree to which they view mental exertion as dangerous and how much they avoid mental exertion. And you can see there's a relationship that the more people are scared to exert themselves, they perform a little worse on tests of attention and memory, suggesting they're kind of holding back a little bit, or not being afraid to kind of give it their all. Now, these effect sizes are pretty modest. It's correlational design. It's helpful to see studies like this from a group in the Netherlands. It's an experimental design where they invited patients to work on a group of hard or challenging tasks. The example I'm showing you here are anagrams, where you have like an easily solvable one in comparison to a much more difficult or impossible, unsolvable anagram. And people who are high on catastrophizing spent more of their time doing the easy one, suggesting again that they were avoiding mental exertion. All right. So how do people avoid? I mean, the word avoidance typically conjures more kind of frank avoidance, where people are just not doing stuff, like not leaving the house, declining social invitations, not going certain places, etc. And absolutely, it can mean that. But I just want to also highlight that avoidance can be subtle in what we refer to, and this is a term from the anxiety disorder literature, as safety behaviors. Which basically means doing the activities but differently, and this can be consciously or unconsciously, in a way to keep yourself safe, like prevent symptom flare-ups, for example. So we may see people go places that have some sensory stimulation, but they're wearing earplugs or sunglasses. They're on the computer, but they're dimming the screen and they're scrolling more slowly. They are driving, but they don't want passengers in the car, don't want the radio on out of fear that they could be distracted. And there's lots and lots of these examples, but yeah, just important to be aware of those kind of subtle forms of avoidance. We might also talk about why people are avoiding stuff, like what is motivating them or what are they afraid might happen. The first, this is from qualitative work, interviewing patients about it. The first three I would characterize as fears, and the last two, just to point out there that there are, other reasons other than fear why people don't do stuff. One is depression; they don't feel up to it, or that they're kind of just strictly following medical advice. But the first three, I think, are quite common to prevent symptom flare-ups. So I don't want to do anything that's going to bring on a headache or dizziness or whatever it is for the person. Social disapproval. They don't want to look like an idiot or make a fool of themselves by, you know, forgetting somebody's name or something like that. Um, to not wanting to get another concussion, so they might feel that their brain is vulnerable and any bump on the head could do them harm, and so that they're going to limit their behavior in that way. And there's at least one other fear that I find is common, not highlighted here, and that is kind of a overuse injury where people are scared to mentally exert themselves or out of concern that it will cause brain damage. So I mentioned catastrophizing before. It is we think, an important intermediate variable. And the idea here is that people are not only avoiding because their symptoms are bad, but also because they have a very negative or exaggerated negative view about their symptoms. So if you're somebody who thinks a lot about how intolerable your symptoms are, concerns about how long lasting they're going to be and how they affect your life in various ways, you're going to be more motivated to avoid doing anything that would make those symptoms worse. That's essentially how catastrophizing works, and we think kind of mediates this relationship between symptoms and avoidance behavior. I'll return a little bit to the neurobiology of fear avoidance. So there's some evidence from translational models that traumatic brain injury increases fear generalization. So this is how fear generalization is studied in mice. There's one kind of setting or context that is truly aversive, say the risk of shock, and another that is similar but is neutral. So maybe the room looks similar but not identical, and they never get shocked. So rats with a sham injury can tell the difference between those two scenarios, and rats with TBI tend not to. They just so the y-axis here is freezing or panic behavior, and they freeze kind of indiscriminately in the context that they were that was associated with a real fear, and another that is similar but not identical. Here's more work. This is from Andy Hoffman at UCLA and folks, showing a similar thing, but also what's happening in the brain with fear generalization, and that is an increase in excitatory related proteins in the amygdala, and in other studies, heightened connectivity of the frontal amygdala circuit. And there's some evidence for this hyperconnectivity in humans as well. This is data from Kevin Bickard, also at UCLA, showing how frontoamygdala hyperconnectivity, so this comes from resting state fMRI, and that's on the um, x-axis rather, is associated with worse symptoms of various kinds, and maybe also with poor autonomic function. So one of these here, this one, shows lower heart rate variability in association with frontoamygdala hyperconnectivity. All right, so we're going to move from looking at kind of correlates to consequences down the road. Why is fear avoidance a problem? So this was our first prospective longitudinal study where we measured fear avoidance behavior at clinic intake and found that months later, patients who were high on fear avoidance tended to have worse symptoms, worse disability, and were more likely to have a depressive or anxiety disorder. We replicated this finding in a new sample and extended on it in a couple of ways. So here we're controlling for symptom severity. That's the RPQ score in model 3 there. So we can show that it's not just that people are more avoidant because they're more symptomatic. And we also incorporated a change variable here. So people who, so we're able to show that people who are more symptomatic at clinic intake and stayed more avoidant or became even more avoidant over time, both of those variables were associated with worse symptoms at follow-up a few months later. And this has been replicated by several other groups now. So this is more data from the Netherlands. Here they took a sample of people with concussion and orthopedic controls and did a multivariate latent class growth analysis to identify classes of people with similar recovery trajectories. And you can see that some of these classes, like those in orange and pink up here, are doing worse. And those groups also tend to have more fear avoidance and more catastrophizing. Here's one more example. So these are adults seen at the University of Pittsburgh Medical Center's sports medicine concussion program. They measured fear avoidance at clinic intake and dichotomized it as absent or present. And you can see that patients who had fear avoidance took longer to recover, about 50 days versus 27 days on average. The fear avoidance group, interestingly, also had slower reaction time on impact scores, greater symptom provocation on VOMS testing, and more anxiety and depression. Okay, so maybe I've been able to convince you so far that fear avoidance is unhelpful. So what can we do about it? Well, I suppose that the first thing we'll need to do is find it when it's there. So there are some measurement tools to see how fear avoidant people are. We tend to use the FAB-TBI scale in our studies, in part because it has clinical reference values, so you can understand whether your patient is avoiding more or less than others with concussion. But I've highlighted a few other examples here as well. These have all just come out in the past couple of years. In terms of treatment, so I'll just walk you through our journey in figuring out what to do for fear avoidance. Our first crack at this was using an off-the-shelf treatment manual that was originally developed for chronic daily headache by a health psychologist named Paul Martin in Australia. So this is kind of a proof of concept that we can use that approach in a new population, people with headaches after concussion. So his idea was that with headaches, the conventional advice is avoid your triggers and you'll be fine. But what Paul Martin thought was that actually that may be part of the problem. And if we gradually expose people to their triggers, maybe they'll lose their bite, right? People will be more able to tolerate it. So that's the approach that we tried here. Of course, some headache triggers like drinking too much alcohol and not sleeping well, those you should probably continue to avoid. But I'm talking about things like stress and lights and that sort of thing. So this is just a small case series. The outcomes were kind of variable, ranging from, like in this case, you can see somebody has, after treatment, 0 headache days and much fewer symptoms, less cognophobia. They feel great overall on a global rating scale. But then other people who seem to benefit very little or at all. But I think importantly, what we learned here is that the patients were kind of accepting of this approach. The treatment was tolerated, and that was enough to move forward and look at this more closely. um, so we set out to design a more concussion-specific treatment protocol. Was really influenced by this framework from John White and colleagues at Moss Rehab, where the idea is to start by specifying the treatment targets and then work backward through the mechanism of action to select the treatment ingredients, the things that the therapist can do that will act on the target. And so that process led us to 2 targets, avoidance itself and catastrophizing. So with avoidance, again, we're referring to both overt staying away from, but also subtle avoidance. We know from related health conditions that exposure exercises can be helpful and seemed like kind of a natural fit here. And the idea is that we support the patient to gradually interact with the activities and situations that they've been avoiding to build tolerance and learn firsthand that nothing bad happens. That's the expectancy violation thing. And there's also a focus on identifying and phasing out safety behaviors as part of that. And then so catastrophizing, basically a set of beliefs or a style of thinking. So cognitive appraisal, a core CBT strategy, seemed like a good fit for that, as just as a way of explicitly tackling how people are thinking about their symptoms and the dangerousness of activities and so forth. So we developed this 12-session protocol. It's introduced initially, we use kind of a neuroplasticity rationale because people seem to take to that, this idea that you need to give your brain a chance to adapt, right? Neuroplasticity is experience dependent. If you avoid stuff, you'll never have the opportunity to let that adaptation happen, and you really need to be challenged. So we figure out what it is they're avoiding. We build up a hierarchy of steps to get to their goal of returning to whatever activities are important to them. I'll show you an example of that in a minute. The meat of the therapy is the planned exposure exercises, which are done both in session and as homework. And then towards the end, we add in the cognitive reappraisal work. So for exposures, the things to pay most attention to are, one, we want to make sure that we're picking the right kinds of activities and situations. So in particular, ones that people find uncomfortable, challenging, or perceive as dangerous. So the actual activities and exposures are going to look different from person to person. It sort of depends on what it is that they're avoiding and why. The progression is collaborative, so we work with patients to figure out, okay, you're here, if we could kind of nudge you to do a little bit more, what would that look like? And are you ready to do that now? So there's a lot of kind of negotiation and back and forth with that. I mentioned already the expectancy violation. So before each exposure exercise, we have people predict what they think is going to happen or what their worry is, what they're worried might happen, and so that it's more kind of clear if it doesn't play out that way, that there's some learnings. It's important to repeat exposures. That's the only way to get habituation. So you can't just do something once and then your brain adapts. It takes doing it over and over. We want to have the exposures done in multiple scenarios. So, we don't just want to be more comfortable in, say, one particular coffee shop. We want to be comfortable in all kinds of situations that have, lots of movement, traffic, and noise and so forth. And again, attention to safety behaviors along the way. So this is one example of what an exposure hierarchy can look like. So the situation is, this is a person who was injured in a motor vehicle accident, is trying to get back to work, and they have about an hour commute to work. It's a combination of city driving and highway driving, but have had some difficulty being in the car, tend to feel dizzy, which the um, patient attributes to sort of things moving quickly within their visual field. Also gets some anxiety whenever they were go back in a car, which of course seems connected to how they were injured in the first place in a car accident. So there's some worries about risk of re-injury, and some safety behaviors as well. So, initially she was being driven not only to work but everywhere, and tended to close her eyes as a way to like not see the moving objects that were bothersome to her. So in therapy, so we map out this hierarchy, which is basically like one step more from what you're already doing, and then progressing up towards the goal, which is to be able to drive to the office 3 days a week. And so even before they get in the car, we might be doing some exposures that just involve exposure to visual motion, which could involve like moving the head, or in this case, watching YouTube videos where you have that first person view on a roller coaster or other kind of busy scenes, and eventually working up to driving, but starting with more smaller manageable goals, and working up from there. Okay, so using this protocol, we did our first randomized control trial, really focused on the feasibility of this approach. So we recruited adults with persistent symptoms and randomized them to this graded exposure therapy package, or to another kind of therapy that didn't directly target fear avoidance. And we found that, generally speaking, it was feasible. So patients signed up, they viewed the graded exposure as a credible treatment, like it made sense to them. We found that the therapists were able to follow the treatment manual. Patients, generally did their homework and completed outcome measures. So those are the kind of feasibility benchmarks that we were looking for, and largely met. We also found some evidence for treatment specificity here. So in the graded exposure group, fear avoidance came down more than in the comparison arm. So there's something specific about the content of the therapy that's driving this reduction in fear avoidance behavior. That's the FAB-TBI scale I mentioned on the y-axis. Now, we didn't have another kind of control group in this study who got no treatment or just got usual care, but we did have access to a usual care cohort from another study that recruited from the same clinics around the same time. So it made for a comparison of sorts, and what's often referred to as a historical control design. And here it looked like there was benefit of graded exposure compared to usual care, greater reductions in symptom severity as measured by RPQ from pre to post treatment. Also want to highlight some work from colleagues in the Netherlands who, instead of our approach, which is like a once a week for 12 weeks, they brought patients in to stay at a local hotel and do 12 sessions in 1 week. So really intensive, condensed protocol of exposure therapy. And these are case studies where you can see um, problems before they start exposure that get better after exposure. So interesting kind of approach there. The next thing our group did was pursue a more kind of definitive phase 3 clinical trial. So we got funding for this a couple of years ago. It's a multi-site randomized controlled trial recruiting from 8 or so clinics across 3 Canadian provinces. These are adults all with persistent symptoms. And we've just recently finished data collection and started on analyses, so I can share a little bit of this with you at least. So this study had 3 arms, graded exposure, same protocol I told you about. It's delivered entirely over Zoom. We had a usual care arm that we enhanced a little bit just to make it credible with some kind of supported self-management stuff. And then we included an aerobic exercise arm. One, because aerobic exercise is a fairly well-studied alternative treatment option. We want to understand what works for who. So we're looking at some moderation kind of analyses here. But also because we think exercise may in work at least, excuse me, may work at least in part through the same mechanisms as graded exposure therapy, where you're basically teaching people that activity is safe, but more implied than explicit. Yeah, so I think I said most of this stuff. They had to have multiple moderate severe symptoms to get into the study, a couple of exclusion criteria if they weren't able to exercise, involved in personal injury litigation, failed performance validity testing. This is the final sample, so we aim to recruit 220 patients. We ended up with a little bit more than that before we ran out of time and money. You can see there are randomized graded exposure, exercise, enhanced usual care. So, these are people in their kind of mid to late 30s, about 2/3 of them women, identifying as white. And they're about 5 or 6 months post injury on average, and they have lots of symptoms. And here is the very preliminary raw data I'm showing you here. So we're doing, modeling with this data now, but just looking at how the groups do over time. So the red line is the graded exposure group. um, Blue is usual care, green exercise. And it looks like, I think there's going to be more nuance to the story, but generally speaking, um, groups who got exercise or graded exposure do a bit better than those who got the usual care, but there doesn't look like much difference between exposure therapy and prescribed exercise, interestingly enough. And just to be clear, these are all comers, so these are not just people who are high on fear avoidance to begin with. This is a fulsome sample, including people who are both high and low on fear avoidance to begin with, and so we're doing some subgroup and moderation kind of analyses to look at that more closely. I'll just mention some other ongoing work that I'm aware of. This is a group from Denmark that has a kind of a broader intervention approach, but one of their targets is fear avoidance behavior. So this is a trial that's also recently finished and should be published soon. And then work from Kevin Bickhart again at UCLA, looking at transcranial magnetic stimulation of the frontal pole in order to modulate amygdala frontal circuitry here, seeing if that can help fear avoidance. So this is brain stimulation that's paired with exposure exercises. And you can see in this example kind of a reduction in the frontal amygdala connectivity. And the hope is that this will also be associated with improved fear avoidance behavior and symptoms in general. This is ongoing work. I think they're a little over halfway recruiting for this study, but just to highlight, an alternative approach at kind of getting at the same thing. Yeah, okay, great. I'll stop there and hopefully we still have some time for questions.
Noah, thank you so much. That was fantastic. I'm always amazed how much information you can put into a short period of time, and the volume of work that you and colleagues in this space are completing is absolutely commendable and impressive. So thank you. It's a very
Thanks, Nick.
exciting field, and I think a lot of people are going to benefit. You said the words getting people back to doing the things they need, want, and I like to say love to do. And I think really tapping into this idea of fear avoidance and sort of rehabbing with that in mind can be, I think, so massive for so many people. So thank you, Noah. That was fantastic. We're now going to open it up to some questions. So anyone on the line, please use the chat function and you can put questions into the chat, which I can pass along to Dr. Silverberg on your behalf. While you're warming up your fingers and typing, I do have a question or two for you, Noah, if that's okay. So first off, this idea of fear avoidance rehab and thinking about aerobic exercise rehabilitation. And I know in the field of concussion, there's been a lot of focus and rightly so, on exercise as medicine,
Yep.
with some really good results, right? And something that we're seeing some good benefit for a lot of people, but not everyone loves exercise or loves doing exercise or keeps up with exercise. We all have our best intentions. Where do you see fear avoidance rehabilitation sort of fitting into that mix? Is it like we pair it up with exercise, or is it some folks are going to benefit more?
Mhm.
How do you see it all interacting down the line? Because I can see it being
Yeah.
exciting.
Yeah, probably any of those scenarios. So there are some people who were very physically active up until the time of their concussion, maybe even sustain their concussion in a sporting context. And the thing that they're afraid of is getting their heart rate up and exerting themselves. They're going to be great candidates for aerobic exercise, right? There are other patients who, haven't exercised in years and might not do well if told, you need to start going on the treadmill after concussion. So that's one scenario. Another is, I would say, the nature of their fears. Um, so sometimes it's not physical exertion that concerns people so much as mental exertion or other, sensory stimulation. And so one advantage of the graded exposure therapy protocol is that we can tailor to those specific fears. So that would be another reason perhaps for favoring that approach over exercise. But the two can absolutely be complementary as well.
That's great. Thank you, Noah. Very exciting. Again, inviting those on the line to please share in the chat any questions. I'll also invite you to raise hand function if you would like, if it's easier for you to ask a question using the unmute function. In the meantime, another question for me, Noah, and I can see your passion around this work. You've really led the charge, blazed the trail, and I can see you getting excited about the work when you talk about it. So I guess my direct question around that is, what is it about this work that excites you the most? Sort of the potential, where it goes, what you've done, what gets you most excited about this area of study?
Well, I think like a lot of people working in this field, there's no shortage of these patients, and it has been less than clear what they need, what it is that's going to help them. And we've been working, largely off, clinical intuition, but haven't had the kind of evidence that so many other areas of health and medicine have in terms of, rigorous randomized control trials informing practice. And I'm excited to see us at least taking steps in that direction. And in particular, not just having, a list of treatments that work in general, but getting to this more kind of personalized rehabilitation approach where we can kind of match people to the treatment that's going to most benefit from them. So, yeah, I don't know. That's exciting for me.
It's exciting for me too. I appreciate that, Noah. That's great. We do have a question coming in through the chat. So thank you for the individuals who are able to share some of these questions. So the question for you, Noah, is, are there any premorbid risk factors to develop fear avoidance?
Probably, but I don't think we know what they are. If you're forcing me to guess, um, I certainly any history of mental health problems, including anxiety, history of other health conditions for which fear avoidance is often contributory. So I'm thinking about functional somatic symptoms and syndromes, for example. Um, Maybe kind of personality style, like neuroticism. Um, but yeah, but we don't know. One that I am curious about is people's experience with prior concussions as well. I imagine that's going to drive how they go about dealing with a new injury.
It's fantastic. Thank you, Noah. Thank you for that question. Another question coming in through the chat, which I'll read for you here. How might a traditional, in quotations, neuro rehab care team, so for example, SLP, OT, PT, best support post-concussion patients experiencing fear avoidance while maintaining scope of practice? And just for a little bit of
Mm,
context there, we often struggle with locating professionals who can support mental health needs in a timely manner. And this individual asking the question, and thank you for asking, works in a home community setting where we're able to treat patients in functional environments. So yeah,
Yeah.
what do you think around this sort of the more traditional rehab team? How can they support in these situations while still maintaining scope of practice?
Yeah, that's a great question. So I hope not to leave you with the impression that a patient who's exhibiting a lot of fear avoidance behavior after concussion has to be referred to psychology for this specific protocol. That can be nice where available, but I don't think it's the only option. I think there are a lot of things that a quote unquote traditional rehab team can do. Basically taking principles from the treatment protocol that I was describing and incorporating them into what you're already doing. There are also some efforts to kind of formalize what that might look like. Just to share one example, a colleague, Catherine Schneider at the University of Calgary, who does work around vestibular, cervicovestibular rehabilitation. She's interested in incorporating principles of cognitive behavioral therapy to kind of enhance engagement with and the effectiveness of that therapy. So it's a physiotherapist delivering the intervention, but taking some of these psychological principles into their work, which I think is exciting. The study I mentioned from Denmark, their intervention is delivered, I believe, primarily by occupational therapy in tandem with some others. But again, is pulling in some of these principles and treatment strategies. So I'm confident that that work could be done. I guess the first step is just, recognizing when fear avoidance is a likely driver of symptoms and disabilities, or something that's going to interfere with engagement in other rehabilitation activities, and just bringing it kind of front and center within the treatment plan.
Mhm. That's great. Thank you for that question and great response, Noah. Much appreciated. Noah, maybe we'll close off our question period here with just
Mhm.
any sort of final words from you on sort of what's next. I know you did mention a few studies that are ongoing, but what can all of us interested in this space sort of keep our eye on and continue to be looking out for the near or far future?
Yeah, I mean, we're still in the phase of trying to establish what is helpful, and close follow-up to that question, for who. um, So I think we can look forward to that work coming out. There's still lots that we don't know about how fear avoidance works. And so studying it from different kind of psychological and cognitive and neuroimaging kind of angles and qualitative work as well, will add a lot of color, so that we can, again, just better recognize fear avoidance, better kind of explain it to our patients, and help them get over it.
Mhm. Fantastic. Well, Noah, thank you so very much for this work and for sharing it with us today in this way. We're so grateful. So please, everyone, join me in thanking Noah for being with us as part of our IBIA webinar series. And yeah, we wish you all the best with this work, and we'll be keeping a close eye on it and cheering you on every step of the way. So in
Thanks so
closing,
much.
okay, great. Thank you, Noah. In closing, huge thanks everyone for joining us today. Big thanks to IBIA and particularly Jennifer for ensuring that we have these webinars available to all of us. Just put a few notes in the chat just around some upcoming conferences that may be of great interest to many of you. The North American Brain Injury Society meeting coming up in March in Washington, D.C., as well as our International Pediatric Brain Injury Society meeting coming up at the end of April in beautiful Calgary, Alberta in Canada. And also, please join us again for more webinars. You can go to the internationalbrain.org website, click on the meetings tab, and find webinars for the future, as well as postings of past webinars. So without further ado, we will close today. We'll give everyone back a little bit of time in their day. Hope you have a great rest of the day, and we will see you again. Thanks very much.